Hello, everyone. Welcome to week 11. Um, a lot has happened, as we all know, since last week, mainly the election, right? So, congrats to Obama supporters. And for those who supported Romney, well, get ready for 2016. And here's a few of the people you're likely to see standing up for the Republican Party in 2016. Should be quite interesting. As you know, around here, as soon as one election ends, people start getting ready for the next one. So you can believe that people are thinking about 2016 already. As strange as that might sound, and I'm sure we are all burned out on the whole campaigning thing, but there are people already strategizing for the next step. Okay, so this week we're focusing on the basics of Medicaid, Children's Health Insurance Program, and Medicare, really the big public health insurance programs in our country. Now, we've already been talking about these quite a bit, but I'm just going to point out some of the details related to them so that we can just reinforce some of the things you've already learned and maybe clear up any confusion you have related to these programs. All right, first, Medicaid. Medicaid is a program that's run by states, but it's financed by the federal government and by state governments. And because the federal government finances it, they tend to put conditions on the money, or they partially finance it. They tend to put conditions on the money that they give to states. That's not unique, right? Any of us giving money to someone might put some conditions on the money, when it should be paid back, what it should be used for, and so on. So the federal government does the same thing. Some of you know from the discussion, or remember from the discussion of the Supreme Court case, that the federal government cannot put really extreme conditions on providing extra Medicaid dollars to states to expand Medicaid. So the federal government is not being allowed by the Supreme Court to say that a state will lose all of its Medicaid funding if it doesn't expand Medicaid, but they would not receive the funding associated with expansion if they don't expand Medicaid, which is fairly straightforward and obvious. But there are limits to how much the federal government can place conditions on the money that they give states, and the Supreme Court did a good job of pointing out how those limits apply to this current situation. All right. So, as I said before, there are these state Medicaid agencies, and they're staffed with probably about 50 plus people in each state, and they're managing the Medicaid program. The Medicaid program is quite big for states. It makes up probably anywhere between 15 and 20% of some state budgets, and so it's something that they care about. It's some money they're used to having from the federal government. If you take it away, it would definitely have a substantial impact on states. So they spend a lot of time thinking about how to spend this money appropriately. And all states participate, and as we've talked about before, all states are unlikely to participate in Medicaid expansion. I think you're probably going to have more than half participating in Medicaid expansion, but we have a number of Republican governors who are not in favor of Medicaid expansion, and so they will not participate in it, more than likely, unless someone pushes them to do so in a very strong way. All right, now generally Medicaid covers a certain group of people. We refer to these people as categorically eligible. This is, individuals with disabilities, low-income pregnant women, low-income kids, low-income families. Now, what you don't see here, and also low-income elderly, what you don't see here are single adults. And so Medicaid expansion would expand to those single adults. But right now, in most states, Medicaid does not cover single childless adults. Some states have expanded their Medicaid programs to include single adults, but those states are really far in between. Now, the benefits are decent for Medicaid. It really provides all the basic care you need. It pays also for specialty care. One of the problems with the reimbursement or the pay for specialists is it's really not that good at all, and many specialists don't take Medicaid as a result. But it is decent and takes care of all your basic needs, and you can find primary care practitioners that are going to accept Medicare in any state. As I said before, it's jointly financed by states and the federal government. So how does this work? The federal government pays a certain portion to each state depending on how much money the state has. So the per capita income for a state. So a poor state like Mississippi gets about 73% of its financing from the federal government for Medicaid, and then they kick in about 27% on their own. So they don't pay for the majority of the program. And then states like Massachusetts have a 50-50 share because they have more money. Um, with regards to provider reimbursement, I think I said most of what I wanted to say here. It's usually now in most states, managed care organizations are running the the benefits for the Medicaid program. So you'll have a state office that's a state Medicaid program, and they'll create a contract that will they'll create a request for proposals and for bids, and various managed care companies will bid on this large Medicaid contract so that they can manage the Medicaid benefits for a particular state. And often states will have maybe two or three different managed care companies. So let's say they have, Blue Cross Blue Shield, Aetna, United Health, and all of those companies have a certain share of the patients in a particular state. And the people who receive Medicaid in the state are allowed to pick one of those. Usually, sometimes they may have to pick one in a particular region, but they usually can pick one of those plans, and that plan will then manage their benefits, and that plan will determine where they can go to see the doctor and so on. And physicians will contract with these various managed care plans in order to get payment for their services. So managed care plays a big role in Medicaid, and many citizens aren't aware of that. I want to just make sure you guys are all aware of that. In every state at this point, managed care is running most of the administering most of the benefits related to Medicaid. So the state program would tell the managed care companies what they want, but then the managed care companies would take it from there. You might ask, well, why is that? Why is the private sector involved in this process? And it turns out that they're just much more efficient than the federal government when it comes to managing benefits for poor people. They're not as efficient at managing benefits for the elderly. So in the Medicare setting, managed care companies have not been successful, and that's probably because there are sicker patients among the elderly, and the profit model just doesn't really work out. The numbers don't really work out well when you have that many people on your insurance who are sick and needing care. All right. Medicaid offers waivers. These waivers are really a way for state governments to innovate in Medicaid. So they might, as I said before, include single childless adults. They might try to increase the amount of cost sharing they require for certain things in order to increase utilization of some types of care and decrease utilization of other types of care and so on. They like to try a lot of different things. And so when you've seen one Medicaid program, you've just seen one Medicaid program. Each state is doing something slightly different because of waivers and all the various options that the states have. So these are really, state programs, and you just kind of the general themes that they tend to cover certain categories of people. But after that, it's really, you really have to look at the state Medicaid programs in detail to get a sense of what they're doing and not doing. All right, so how's the Affordable Care Act going to impact Medicaid? Well, if they expand Medicaid, and your book assumes that they will, and because no one actually thought the Supreme Court was going to examine Medicaid expansion, and your book's made up of a couple of my colleagues, and I know they didn't think that the Supreme Court was going to review that issue. So they assumed that there would be expansion in every state. Well, it turns out that's just not going to be the case. And so we're not going to have expansion in every state for childless adults. We will have expansion for children. So all states have to cover children at 133% of the federal poverty level and below. So that's children who come from households that are making about 40,000 and below. I think is the figure now for a family of four. It's lower if you have a family of three or if you're a single parent. For a single parent, it's around $14,000 for 133% of the federal poverty level. Immigrants, even legal immigrants, it's not undocumented immigrants. So legal immigrants have to wait 5 years before they can access Medicaid. But states now are going to have the option to at least cover immigrant pregnant women and children who've been in the country more than 5 years. Let's see. So the Affordable Care Act will actually pay for the Medicaid expansion with federal dollars for the first 3 years. For first 2 years, and then slowly move down decrease the amount that the federal government is going to cover down to 90% by 2020. So, that's still a good deal. If someone told you they want to start some program in your county and they're going to pay 100% of the cost and it's going to go down to 90% and it's going to be somewhat beneficial to your people in some way, that's something you should not immediately walk away from. You should figure out what are going to be the potential benefits of that program and figure out if it's logical to take it on or not. And so some states are just thinking that 10% in 2020 will be too much for them to cover, and so they just can't handle that expansion. But in other states, that's really minuscule, especially since the federal government is going to cover the vast majority of the costs. And I'd argue if you're a smart state, you try to find a way that 90% is really used to cover most of the program, so that beneficiaries, people who receive Medicaid, don't actually ever get to your 10%. And if you can figure out some ways to have your 10% concentrate on things that really are not requested services that often. But anyway, I think it's states are going to take different approaches on this, and I think there can be ways for them to figure out how to get the most from these programs. Now, the Department of Health and Human Services has actually stated that states can expand Medicaid and get the 100% federal funding for a couple of years and then just stop. So they can start it and stop it whenever they want. So that says to me, why not do that, right? Why not just expand Medicaid for a while in your state and stop it? I think some states don't want to create that sense that that the program is open to more people and then pull it away from the citizens. They'd rather just not go down that road because they know people will get used to it and people will probably protest if it's taken away. But still, I don't know. It's something I think states should really give some serious consideration to, instead of just ignoring or sort of pushing away the funds. But we'll see. There's going to be a lot of variation with regards to Medicaid expansion. All right. Now, for the Child Health Insurance Program, this is just a way to cover kids of working poor families who don't qualify for Medicaid. So let's just imagine someone is $1,000 above the Medicaid eligibility. And that might sound like a lot because the eligibility is fairly low anyway. In many states, it may be 100% of the federal poverty level, which for a family of four is going to be, a little less than 40,000. So you might say, well, that's a fairly substantial amount of money to have $1,000 above the eligibility. But as you know, that $1,000 doesn't really go very far in any state. So many times that money is not enough to pay for health insurance. Definitely $1,000 for a family of four wouldn't be enough for any individual insurance policy. And these are people who are not getting insurance from their employers, so their only option is to go out there into the individual insurance market, and they're just not going to get a good deal. So the people realized this, and they realized that it was really hurting children. So the Child Health Insurance Program was created in order to deal with that problem. So that now working poor people can at least not worry about their children having health insurance. Now, one of the problems here is that if you are someone who doesn't have health insurance and you're getting sick all the time, but your kids have health insurance, you might not be able to help them, use that health insurance as often as they should. Or maybe you're someone with unhealthy habits, and so you're not necessarily interested in taking your kids to the doctor on a regular basis. So sometimes families can thwart. Lower income families might end up thwarting their kids from getting the benefits they need because of their own various problems and health behaviors. But frankly, that can happen at any income level, and it's just it's just something that you have to deal with for these types of programs. In general, I'd say this is quite beneficial, and most parents. Who are lower income really want their kids to have insurance, and they take advantage of this program. And all states participate in it. There are different options for how states can add CHIP to their current infrastructure, their current public health insurance financing structure, and they can add it to their Medicaid program. They can create a separate program, some kind of hybrid, and stay on all of these different things. Now, what's nice about CHIP is that the an incentive for states to participate was a higher match rate. So instead of states getting this 50-50 match from the federal government on average, they get about a 71% match of federal funds to their, around 29-30% of state funds. So they get more money basically from the federal government to cover these kids. So that's a strong incentive to get out there and create these programs and offer health insurance to kids of working poor parents. All right, and the level of eligibility is much higher than Medicaid. It's 300% of the federal poverty level. As I said, typically for Medicaid it might be 100, 110%. With the ACA, it's going to expand to 133%. This is more than double that amount. So CHIP definitely covers a lot of working poor kids. And the idea is that after 300%, your family probably has at least one worker. If you have a typical family with two parents, at least one worker will have access to health insurance. And even if you have a single parent, often at that level, they're going to have access to health insurance on their job, or they have enough money to find some plan that's affordable. And especially with the Affordable Care Act in 2014, there are going to be a number of affordable options available through the state health insurance exchange programs. So people at this income level should be able to find something that's affordable and useful for them, so that they're covered and their kids are covered at that higher income level. All right, the benefits are fairly extensive. They're not as extensive as Medicaid, but they do cover all the basic services that kids need. Kids in general tend not to need a wider range of services, or as wide a range of services as adults do, as many of you know. So the benefits don't need to be as extensive usually for kids. Now on to Medicare. So Medicare is really a federal government program. It's the states don't administer it. They don't get money for it, but they love it because it takes care of their elderly. And otherwise, states just wouldn't have the money to do this. They don't. So this is something that we as a country have decided that we don't want our elderly drifting off into poverty and illness because they don't have money to pay for their health care bills. So the way Medicare works is that people pay into it when they're working, and then later on in life they get the benefits. If you don't pay into the Medicare system, you don't get any benefits later on, and that's not surprising to people who come to the U.S. thinking that all older people get health care, but that's just not how it works. You actually have to pay into the system in order to benefit from health care. Sorry, I'm a bit sick in case you didn't notice. Sorry for the sniffing or so. So Medicare covers two main groups: elderly people and disabled people. The elderly group, you guys are used to this. You know that by 65 you'll have health insurance. For people in my generation, I'm in my 30s, we are much less likely to have a pension that's going to provide health benefits and also just basic retirement funds for us. So we actually have to wait until age 65 and try to keep working until age 65 so that we can access this health insurance that we're paying for. it turns out that we'll have to work even longer because the age changes depending on when you were born. So for my age group, it's now up to 67. So you're going to have to work until age 67 before you actually start getting those benefits. And the number is likely to keep changing. This number was set back in the 60s when the life expectancy for the average adult in the U.S. was around 67 years old. So the notion was that people would get Medicare, they'd have it for a couple of years, and then they die. Well, it turns out now our life expectancy is up in the 70s, and so we're most people might live another 10 plus years. Many people live out into their 80s and 90s these days. And definitely baby boomers are going to be doing that. So the amount of money that they put into the system is much less than what they're going to be getting out of it, unless they stay extremely healthy. For those really healthy elderly people, they're probably not going to use as much money as they put into the Medicare program. But for those who aren't healthy, they're going to get much more out of it than they put in, more than likely. So we really got to think about what the age limit should be for getting Medicare benefits. Now the trick here is that if you retire early and you need health insurance, where are you going to get it? Because it's going to be expensive, right? If you're 55 and you apply for health insurance from the individual market, your premiums might be $500, $700 per month because they know you're probably going to need that money at some point. And there's a strong disincentive for you to actually purchase insurance. And even with the Affordable Care Act, insurance companies can discriminate based on age. That's one form of discrimination that wasn't removed. That's a pre-existing condition in itself in some ways. And it's just, if insurance companies had to take that away, you would really gut their business. So, you know, as you age, you really got to take care of yourself these days because you're not going to have that pension to fall back on, and you've got to get to a certain age before you can get these Medicare benefits. I think the state health insurance exchanges are going to help out some older people who've retired early because at least they'll have some option that's more affordable. But as I said before, age can be used as a way to discriminate against these people. So they will still face higher rates even if they try to tap into the state health insurance exchanges because they are older and the rate can be set higher for them. Now, for disabled people, you actually have to receive Social Security disability insurance, which is just based on the fact that if you have a disability, you're not going to be working and you need some type of assistance. So that's part of why Social Security exists. So it gives you a monthly check, and that lets the Medicare see that you have a true disability. It's lasted for 2 years, and you're going to need health care assistance because you're truly, quote unquote, permanently disabled. So for people who are permanently disabled, sorry, they get Medicare funds. And also people with end-stage renal disease, and that's because the cost of covering people with end-stage renal disease is so high that the majority of people who have end-stage renal disease, which is essentially kidney failure, cannot cover costs. So a special category is created just for these individuals. What does Medicare cover? Well, the part of Medicare that we all pay for with our payroll tax is Part A, and that covers hospital insurance because that's really where we spend the most money in healthcare. It's expensive to go into the hospital for anything, and so the thought was that you definitely needed to cover that with Medicare, and then there's some other things that over time were added to it. So Part B is also a part of Medicare that covers mainly like clinical visits, outpatient things, and some preventive services. But that actually has a premium attached to it, so that actually the premium is a little higher depending on what your income is. And if you're a really low income person, then you're not going to have to pay a premium for Part B. And you could also get Medicaid too, so you could have Medicaid and Medicare. Part C, you hear a little bit about, it's called Medicare Advantage. This is where the Affordable Care Act tries to save some money by paying managed care companies less money to offer Medicare Advantage to seniors. Of course, some of those companies say they can't actually offer quality services for a lower price, and that's what they should say. But we'll see in the long run whether or not they continue to offer managed care to elderly people. But these managed care companies, it turns out, are actually costing more than the traditional Medicare, which is a fee-for-service model where docs are paid for whatever they do, instead of having this managed care company intervene and try different ways to contain costs. Turns out that the managed care companies are actually charging the federal government more to provide their services than the fee-for-service model charges through various physician services that are being provided and hospital services that are being provided. The prescription drug coverage, Part D, is fairly new, and it was passed during the Bush administration. It was basically a way to provide seniors with drugs because, as you know, many seniors have a number of pharmaceuticals that they need to keep them alive and keep them healthy, and the costs were just too high for many seniors. They couldn't cover it out of pocket. They didn't have any other form of insurance that would cover the prescription drugs. So the thought behind this is that we needed a federal program to take care of this essential product and service that seniors needed to tap into in order to stay healthy. The financing, as I said before, is payroll tax for Part A. Part B is paid for partially with tax revenues and partially with premiums, cost sharing, deductibles, a bunch of out-of-pocket costs. Part C is paid for in the same way as Part A and B. It's just the managed care version of Part A and B. Part D is paid for with federal tax revenues, but also with monthly premiums for those who can afford it. For those who are really poor, they don't have to pay any of these out-of-pocket costs. Now, there's something called a donut hole for Part D, and you hear a lot about this donut hole, and you definitely used to hear more about it than you do today, because the Affordable Care Act is actually helping to slowly close the donut hole. Now, what is the donut hole? Well, initially, a beneficiary, someone who's receiving Medicare, has to pay a deductible, typically, and so they will pay maybe about $250, $300 initially before they can access their prescription drug coverage. So they start out paying some money on their own. Then after that, Medicare starts covering, and they cover up to about $2,830, so $2,830 that Medicare will coverage. And then the Medicare coverage will stop. And that stopping of the coverage is the beginning of the donut hole. So coverage will stop until you get to about $6,000, right? $6,440 on this illustration. And so that's when the coverage will kick back in. So the question is, well, what do people do, right, after they get to this 2830 number all the way to 6440, right? That's almost another almost $4,000. And so where are people going to find this money? We're talking about elderly people who don't have the money to pay for these drugs. And we're also talking about people who need these drugs, and without them, they would have worse health outcomes, right? So how are they going to cover this? And so many people thought that this was a problem. It was created this way because of the money that was available, and because the thought was that most people would not get to that donut hole. It turns out that a lot of people were getting to it. So what's happening now, what's already started to happen, is that people receive rebate checks, so that when they were paying money into the donut hole, they actually were getting money. They actually now get money back based on the amount they were paying. So they got some rebate checks back, essentially, to help out with the expenditures they had on the donut hole. And then the Affordable Care Act calls for a slow closing of this donut hole. So a certain percentage of the costs during that period are going to be covered by Medicaid. It starts off with 50% coverage, and it goes up to 75% coverage by 2020. So over time, most of the costs in the donut hole will be covered, but there will still be something for individuals to pay, so some level of co-pay, essentially, that people will have for the prescription drugs. Now, for people who are really low income, you might ask, well, what do they do? Because they still might not have that 25% left, even if the federal government is covering 75%. For those individuals, they don't actually have to pay the additional cost sharing, and they have Medicare Part D coverage that's actually free. All right. Um, so how are physicians paid on Medicare? They're paid mainly on a fee-for-service basis, unless they're part of the managed care approach to Medicare, and then they may get a capitated amount. So they may get a lump sum to take care of a certain amount of patients, which means they're going to do whatever they can to cut costs to keep that lump sum as high as possible to put that in their pockets. Hospitals get what's called DRGs, diagnostic related groups. They're basically groupings of illnesses and all of the treatment related to that illness, and hospitals are given a set amount of money for taking care of people. And the idea is to incentivize them to do as much as they can with that amount of money and to provide quality care with that amount of money. And other things that the Affordable Care Act is doing to change Medicare. For one, it's going to decrease payments for hospital readmissions. In some cases, if people are being readmitted to the hospital for something that they just left the hospital for, and something the hospital should have taken care of, then the hospital will get no Medicare payment when they readmit that patient. And that's a really strong incentive to improve the quality of care when the person is in the hospital. Because what Medicare is finding is that hospitals, for some reason, were just letting these people go out of the hospital and come right back in, and then they kept charging Medicare a lot of money for this stuff. So Medicare was thinking that the hospitals must be letting these people out too early, or must not be providing them with a high level or high quality of care that they should be receiving. So that's going to be one change. Another change is the coverage of preventive services. We talked about that before. It will happen without cost sharing, so that's out there already. So all of your family members on Medicare should be using all of the preventive care services that are available to them because they're essentially free. The donut hole, as I said before, is slowly closing. There, within the Affordable Care Act, there are proposals to lower reimbursement to physicians. Those proposals, there were policies that lowered reimbursement to physicians. That policy was later amended so that now the physician reimbursement rate was not impacted. But this is something that has not been dealt with well by Congress at all. Congress keeps pushing it off to the next Congress, and they really haven't dealt with the fact that Medicare has to adjust the amount that it pays out to health professionals in order to stay solvent. It's just been growing too rapidly, and it's got to curve and start to plateau. Many physicians say if that happens, that they're not going to provide care to Medicare beneficiaries. So this has to be done gently, has to be done in an appropriate fashion with the various physician groups out there and other health professionals out there to make sure that people can that the Medicare beneficiaries can still have access to the doctors and other health professionals that they need. And then you heard a little bit about the Independent Payment Advisory Board. That's really a board to try to insert more innovation, different approaches to paying for valuable care and quality care through Medicare. And the same for the CMS Innovation Center. A lot of these boards are really just focused on innovation. They're not people sitting around trying to interfere with the care your doctor provides and what you receive. Insurers, whether they're public or private, have always played a role since they've been around, have always played a role in determining what you receive because they determine what's covered. You can always cover it yourself for cash, but the insurer, in order to stay in business and in order to provide a certain level of services to the majority of the beneficiaries, it just cannot pay for everything. So there are a lot of tough choices that you have to make when you're trying to create these benefit plans, and these various boards are around really to try to innovate and come up with good ways to make sure the American taxpayers are getting as high a quality of care as possible for the price that they pay. And that's mainly what they're focused on. They're not really trying to they're not trying to kill people, and they're not trying to ration care and that kind of thing. All right. Okay. So have a good week. I look forward to reading your discussion comments this week.